Like I said, my name is Jake Harper. I am a reporter at Side Effects Public Media in WFYI, and I went down to Scott County for the first time in March of 2015, soon after the HIV outbreak was announced, and it really, addiction has become my main beat as a reporter essentially since then. So it's had a huge impact on what I do and what Side Effects does in general, I would say. And so we're going to talk about some of the basics in what has happened. I mean, much like our speakers before, what has happened and what can we do going forward. So joining me on the panel today, I have Tonja Eagan, who is CEO of Social Health Association of Indiana, which teaches sex and health education in 10 counties, is that right? Including Scott County. We have Dennis Watson, who's an associate professor at the IU Richard M. Fairbanks School of Public Health. And we have Carrie Lawrence, who is a researcher and also runs, is the associate director of the Rural Center for AIDS and STD Prevention at IU. So thank you guys for joining me. So I guess the first question I have is for Tonja, I think, because you were down in Scott County early on once the outbreak was announced. I think you said you went down in April, right? Can you talk to me about what you saw when you guys started doing work in the schools there?
Sure. So prior to April 2015, my agency, which does teach sexuality health education to youth, was not involved in Scott County. We really weren't welcomed in a lot of rural communities because they're more conservative, if you will. But we received a call from Scott Memorial Hospital and the governor's office, ironically, at the time, to say, hey, we have this issue. Nobody knows how to talk to the kids. We have lots of people down there talking to parents and teachers, adults, and the community, but nobody knows how to talk to the kids, mainly because it is an STD, and everyone wanted to leave that part out. So they were like, can your agency kind of deal with this? So we went in on April 15th and educated in Austin, every 5th through 12th grader, and in Scottsburg, every 6th through 12th grader, on kind of a HIV 101. But what was amazing driving in is, there was this big flashing sign on the highway saying, caution, HIV. And I was like, whoa, okay. And then you get off the highway and there's all these signs, like every 10 feet, needle exchange, this or that. And then at the truck stop and the gas station, there's big flyers saying, caution, HIV outbreak. I mean, it was like stepping into a science fiction movie. And then staying at the hotel there, you heard about every language in the universe. I mean, you heard Chinese, because there were literally people from all over the world who were reporters or researchers staying in Scott County. So it was just surreal, like, where are we? But when we saw the kids come in, we did an auditorium because we had over 3,000 kids to teach HIV 101. When they would come in the auditorium, they would really be looking down and very sad and embarrassed and kind of angry that this outside group, was here. And it wasn't a very warm reception. And the teachers were really nervous and everything and not sure, oh gosh, what are they going to say and all this. And we were told by some community leaders, absolutely do not talk about this being a sexually transmitted disease, which we said, no, we're not going to do that, because everyone believed if they didn't use a needle, they could not get HIV. And that was a serious problem, and that people thought that. So we had to fight back quite a bit with some school leaders and political leaders to be able to explain that this was an STD and what that means and how you can contract it. But our main message to the kids was that this isn't curable, but it is preventable. And it was amazing to watch the kids just in a couple of hours transform from all their fears that their pets were going to die, that their family was going to die, that they can't, they aren't allowed to play outside. Sporting games were canceled at the high school and the middle school because of bullying, and nobody wanted to get AIDS or HIV from the kids. And I mean, it was just horrible, the shame they felt and the embarrassment and the anger and the fear. I mean, one boy broke down crying because his grandfather had surgery in Vietnam, and he was convinced that maybe he got HIV because he heard you can get it through blood. And so just constant fear. They weren't using the restrooms in school. They weren't using the water fountains. They were getting dehydrated, bladder infections, lots of fear. And the teachers, too, didn't know answers. So they would hug my staff. They were crying. So it was a very surreal moment. But when those kids left the auditorium, they were standing tall, and you could tell it was the beginning of saying, okay, this is preventable. It's not a death sentence, although unfortunately many of them did think that coming in, which was really sad to see.
Speaking of prevention, Carrie, I was hoping you could just sort of give, I think, in Indiana at least, syringe exchanges have been pretty controversial, as has sex ed, as has some treatment options for addiction. Can you sort of give the audience a rundown of what does the evidence say about syringe exchange programs?
Well, I think the philosophy behind it is harm reduction. I think you hear that term more used widely now than we had in the past. I'm kidding. Okay. So, and I think that we know that it has been, there's people started looking at just access to new syringes 30 years ago, and in more metropolitan areas, we were seeing it done as well for quite some time. And now, if you've read the recent headlines, we're now talking about safe injection sites. So going from the exchanging of syringes to safely injecting heroin or opiates in a supervised way, is mind-boggling. And so I think that at least as I work even with other states on some of the stigma, I heard even you describe, we've allowed people who misuse drugs or anyone who kind of deviates from what we consider the norm to be on the fringe, and they don't then have access to any kind of prevention or treatment. And they also often experience high levels of just being a despaired population or inequities. I think in hearing about some of the progress around Scott County, what's phenomenal is that they've built this system, this really high-functioning system that includes harm reduction, and it's part of the public health narrative. And as a result, they are seeing these positive outcomes. So I think that, however, because we've had in our public narrative around drug use is bad, and people who do drugs are criminals and they're bad people. And I think as a result, it's kind of we're still on that learning curve. I'm still surprised that our state and our communities are still trying to move through this process of embracing what harm reduction is, whether it's sex education or needle exchange, condom distribution, or just making sure people have access to basic needs, because that's a lot of what I see volunteering at the one in Monroe County, is that I give out feminine hygiene products and blankets in the winter and coats, and lots of referrals to resources similar to what Brittany was describing. So I think that recognizing that this is a social service and a public health service, it's baffling to me, and we know the evidence that's there, it's effective in reducing the transmission of bloodborne diseases, infections, is somewhat a challenge.
Yeah, sure. The other thing I wanted to ask you is that this outbreak brought HIV into really sharp focus as a motivating factor behind passing a law and allowing syringe exchange programs to run. But I guess one of the hepatitis C has been considered like an indicator for whether a syringe exchange is necessary, but it's also an infection and disease that is problematic on its own. Can you talk a little bit about what like the costs associated with treating hepatitis C?
Well, I mean, I think the big thing with hepatitis C is that it can be cured. I think what we were seeing in the beginning is that people were having to almost be in liver failure in order to receive treatment, which to me doesn't make any sense, but that's what the rules were. So, but as far as it's a costly, any kind of treatment is going to be costly. I'm trying to think. You probably know I can't remember the exact cost per.
It's thousands of dollars for the cure.
Yeah, it's a very expensive treatment to be cured of hepatitis C, and again, it's another infectious disease that can be prevented.
Right, and so the other controversial aspect, I mean, addiction is a stigmatized disease, and one of the things that has been another source of controversy has been the way people get treated. Dennis, can you talk to, I mean, we saw the acronym MAT in both Brittany and Dr. Walthall's presentation. Can you talk to me about what is MAT, what are the options, and how available are they?
Yeah, so there's two different terms that tend to be used. One is medication-assisted treatment, and I've heard more recently a lot of people using medically-assisted treatment, which I think is sort of a reaction to trying to get the focus away from the medication and towards the actual medical assistance with it. But there's basically three options that individuals have, and well, there are three options ideally people should have, and they don't all have them. If they have access to any, they usually have access to maybe one or two. And those are methadone, which is a treatment where someone needs to show up to a clinic generally every day to take a dose. After they do that for a while, they can actually take home the dose with them under a strict program, but that is it's highly regulated because it is something that can be diverted to the street if it's not regulated appropriately. We have buprenorphine, which is typically sold in combination in a medicine called Suboxone with naloxone in the strip. It's a sublingual strip that most people take that goes under the tongue. That's a daily dose. That does not have to be something you show up for every day. It can be managed through a physician's office. And then there's Vivitrol, which is typically in the form of a injection that can last for up to a month that someone's given. Both buprenorphine and methadone, while they have psychoactive properties, so Vivitrol does not, and so that can make it a little bit more palatable for individuals. The way that Vivitrol works is that you, and I'm probably using names back and forth, Vivitrol and naltrexone are the same thing, and that when that is injected, it actually just prevents individuals from feeling the actual effects of the opioids.
And what barriers do people face when they need access to one of these drugs? I mean, are they widely available? Are there, I mean, I've heard tales of stigma against those medications when people maybe should be on them.
So methadone and buprenorphine would be the most stigmatized because they, again, have psychoactive properties. People can abuse them. But the Vivitrol, I think the stigma that comes along with that is when people don't understand it completely and they think it's similar to methadone, but once you get past that educational barrier. And then when we're talking about additional barriers to these medications, obviously I said that they're not always all present as an option for individuals, and we know based on the research and prescribing guidelines that individuals, not every one of these drugs work for every person, and that there needs to be some consideration and choice and decision making that happens between the patient and the physician as to what's right for them. For instance, if you have someone who's on a high dose or who's taking high doses of opioids, you should not put them immediately on Vivitrol because they need to be detoxed off that. Many people are not willing to go through that detox, so getting them there can be very difficult. So it would be better to work them into a methadone or buprenorphine treatment. And then also in terms of barriers, a lot of people, because of the stigma surrounding these drugs in general, are told that they should not be accessing them by other individuals in the treatment community who take more of an abstinence-only approach. So that will prevent them even when they show up and it's given as an option to actually taking the drugs. Other issues, obviously, with methadone, you have to show up every day, so travel is a huge barrier to a lot of people. I've heard stories of some people traveling 2.5 to 3 hours one way just to get a dose, their daily dose of methadone, which shows you the extent to which people want treatment if they're willing to do that. And then also, a final point with buprenorphine is we have a lot of physicians and a lot more physicians who have become waivered to prescribe buprenorphine out of their offices over the past several years. However,
there's a federal requirement that you do that, right?
Yes. So a lot of physicians have taken that up, but a lot of them are still very reluctant to take on caseloads of people to be able to, because they don't feel like they can manage them appropriately. It could be because they got waivered, but they still don't have the education where they feel competent, or they're only willing to work with people they know very well that they feel they can trust, or they're not willing to do it because they can't find the appropriate psychosocial referrals in the community for individuals.
And Dennis, you've been involved in evaluating some of the programming going on in Scott County as part of these federal grants. Can you talk to me about some of the improvements that have been made, the changes that you've seen over the last few years since that funding, I guess, got put in place?
Yeah, so currently as of our last report we had, which was February, we had 178 people in treatment at LifeSprings. And I'm guessing we might have the same data, Dr. Walthall. So the 200-something number you had might be the new numbers, just updated. I didn't get a chance to look before coming here. So that's great over a short period of time with this federally funded program from the Substance Abuse and Mental Health Services Administration to be able to offer that. And what we've seen there, number one, LifeSprings has been great to work with. I feel like because of the services they're offering and they've been trying to offer, they've had a tough battle in their community. And then us coming in as these outside evaluators, it was like, whoa, what's going on here? And really taking the time to build some trust and let them know, hey, we're here to help you guys promote what you're doing well, and help you understand what maybe you could do better and correct. And so one of the big things that we saw when we went in there was initially, if you look at a lot of the people that they're seeing, for instance, a lot more people there than the other site we're working with in the north of the state are coming directly out of the criminal justice system. And one of the reasons for that is because there's an opportunity there to catch those people that doesn't exist with the people who are not in the criminal justice system, who are in the community, who are maybe not coming in for services because they're being told they're not in real recovery if they're on medication-assisted treatment. And by the way, I don't think I mentioned this, but these 3 treatments are the only evidence-based treatments for opioid addiction. And then the other thing that I think has been very interesting there that we learned is right off the bat, we got some red flags that maybe there was Suboxone being diverted to the street. But then what we were finding out when we were talking to clients was that the process for getting enrolled into treatment was so cumbersome and long. People were not necessarily seeking buprenorphine on the street to get high. They were seeking it because they didn't want to be taking illicit opioids anymore, and they were waiting to get on treatment. So that was increasing the demand on the street. That we significantly shortened the burden and the process for people to get into treatment. So we started seeing less of those stories that were coming out in our data of people getting it on the street because they could more easily access it. The other final point that I'll say is, the diversion kept coming up there on some other issues too, and every time we caught it in our data, we went to LifeSprings. They had already recognized it, put a plan in place. I mean, they were on top of it. So they've been really good at making sure that any of these concerns in the community about issues like diversion are being handled. And then I'll just say, in terms of our data and our story that we're seeing very briefly, we have seen consistent over every time point that we've analyzed the data, improvements in employment, improvements in both physical and mental health for individuals, reduced use of illicit drugs significantly at every time point, improvements in income, and I'm sure there's more that I'm just dropping out of my mind right now, but our final report's going to be due in August, and we'll see how the program did overall.
Okay, Tonja, what have you seen working in the schools there? What has changed over the last 3 years? What things did you notice at first that have gone away?
Well, some of it's like stayed the same. I mean, in Austin School District, we're fully embraced by the teachers, the principals, superintendent, and we provide 4th, 5th, 6th grade puberty education, human growth and development, and 7th grade an evidence-based 9-part program focused on STD prevention, a whole day on HIV, and also has a 9th day on opioids and drug prevention. And we offer the 7th grade program in Scottsburg, but we're not allowed, per the superintendent in Scottsburg, to teach the puberty programming. So we feel it's a continuum that you need to start 4th grade through 7th grade for prevention, but we're still struggling with that communication. I think, there's a new state law now for parental consent on sexuality health ed, Senate Bill 65, that is going to be challenging for the schools to implement. It requires all parents notified and given a 31-day waiting period, basically, to consent for their child to have sexual health education. So that would be puberty or teen pregnancy, STD prevention, anything that discusses any form of sexuality health, LGBT, anything, has to have parental consent, this 31-day waiting period. Fortunately, the law at this time does allow, if no parental consent is provided, yes or no, then a child can participate. But it does require the schools to manage 2 notifications, a 10-day and a 21-day waiting period, and to make sure those kids, we usually have about a 3% opt-out rate or even less, but now it puts more burden on the schools. The law also requires that the schools don't just send the kids to the library to study, that they provide a full curriculum supplementing that time, which is impossible for a classroom teacher to be 2 places at once. So it's making it extremely difficult to offer sexuality health education, STD prevention in schools. That's basically what the law has done. So we're all going to see how that plays out this year, but we're pretty nervous about it. I think the parental education has increased some, but there's a long way to go there. The teachers really embrace all the education they can get, but the parents still aren't, as engaged. And that's not just in Scott County, that's in every county we serve. So there have been some improvements. I think for us, we added the 9th day opioid prevent. It's mainly focused on peer conflict and peer persuasion skills, because that ties into drug use or tobacco use or sex. And then we also partnered with IU School of Medicine to do our, research on that 7th grade program and pre and post and that kind of thing. And then really have stepped up, I guess, our reach into the community to understand what other resources there are, because we can really be a resource referral for those kids that are often come up to our health educators after class and say, my older sister has this, she doesn't know who to talk to, that type of thing. That's really improved. When we first went there, we gave out a texting service that was a national service, anonymous, for help, and they said they had an 800% increase in calls, or not calls, texts in the first week after our Scott County visit. But I would suspect more people are able to use local resources now, whereas at that time we just didn't have any place to refer them to.
Carrie, obviously 2015 was 3 years ago. That was
Right.
when we legalized syringe exchanges, syringe services programs in Indiana, but it's been a county by county process. Can you talk to me, how have those programs been proliferating?
No. I think that
How many do we have currently?
well, we're down to 8 because of that we lost Lawrence County, and I think a lot of the things we're hearing from both Dennis around some of the stigma around medically assisted treatment as well as education. And I always like to point out that when I taught at Indiana State, I taught health for elementary educators, and I read in our curriculum guidelines that we needed to have HIV education in the terms of we are still the home of Ryan White. And so the fact that this is still a struggle is always shocking to me. But going back to the syringe exchange is that it's an ongoing question, and I think it has to do with the stigma and some of the embedded beliefs and getting people to recognize that knowledge is power, but if you don't know what you don't know, then how likely are you going to make not necessarily the right choice, but also the most common, or kind of be able to integrate this as part of the social norm because of what we're up against. You know, we had a commissioner in Lawrence County quoting biblical scripture as justifying why syringe exchange was bad, and hearing about the enabling. And I mean, it was last year during National Public Health Week that I brought public health students to Scott County because people were saying they were just everywhere. And we walked 6 square miles and found, like, you know, a small container that didn't even get filled. And so I think that that's not the case. It actually makes it's a public safety as well as individual. So I also, when I still do work in collaboration with our neighboring states and find out that Kentucky is 21 and have seen a lot of successes, and yet we're still on the struggle bus. So
I want to invite, we have a microphone over here to your right, my left. We're going to have a Q&A shortly, and so if you guys could line up there for questions, that would be great. I wanted to ask, these stigma is obviously an issue. I mean, we have funding issues. I mean, when it comes to, sex education, harm reduction, medication-assisted treatment, or treatment in general, like, how do we, I mean, you mentioned Kentucky specifically. Is there something that they're doing differently that you think Indiana should change?
Well, and I'm kind of envious of Louisville's health department because they have a whole division focused on addiction and mental health, like within their health department. But just watching their activities around, like, how, I mean, they provide syringe services in church parking lots, and they provide syringe services that are across the street from a school. So, and I think that would, you know, just kind of, they've kind of embraced of, like, being able to provide these services, like in Scott County, where it's needed, like getting to the people, instead of just waiting for you to find a way to come to us. We're going to come to you. And so I think we really still have that moral challenge, like, is this the right thing to do, or is this the right thing to do? So I don't know. I think there's a lot of conversations happening in communities across the state. It's being able to scale it up enough to get and go through the process, which is a lot of effort to do to prove your case that it's needed.
Sure. Yeah, go for it.
I agree. The morality issue is a big one, and recently, actually, there was just a publication called The New Rules in Sexuality Health Education, and because all the federal funding for that now is sexual risk avoidance only, which is abstinence only, and they just eliminated the need for it to be evidence-based. So whenever we've received federal funding, we always had to teach an evidence-based curriculum. That no longer is true as of now, which is really scary. So anyone can get federal funding if they're going to teach abstinence only. When you teach abstinence only, you don't talk about STDs, you don't talk about condoms and contraceptives. So it's a very, very narrow focus that's going to impact the entire country since it's now coming down from the feds. So Voting is very important.
You can register people to vote too. It's syringe exchange programs.
Oh, that's a good, yeah, smart.
Dennis, anything to add before we go to the broader Q&A here?
I'm just really appreciating my comprehensive sex education I received in from 7th grade forward. No, I think that they've hit a lot of it. I would say in addition to, though, getting syringe exchange programs out for people, out where people want to access them, rather than putting them in like a government office or somewhere that people are going to be reluctant to show up, because even though you say it's anonymous, people aren't going to believe that. But also with the naloxone, we're in a similar situation where it's very, very expensive for people to get naloxone on their own, especially when they have an addiction and their money is going to go first towards drugs. But also that there is a lot of free naloxone available, but you have to walk into a government facility to get it, or a friend or family member have to walk into a facility to get it. So if there were ways that we could get that free naloxone out there to be distributed in places that were a little less intimidating to folks with active addiction, then that would be a great way to do it.
I just did a story about that on sideeffectspublicmedia.org. We have a question here. If you could just say who you are and ask away.
I'm Julie Whitman with the Commission on Improving the Status of Children. I'm not sure if you all have the answer to my question or if Brittany is still here. I've heard very little so far about the DCS response to the children of people with substance use disorder, and so I'm wondering what you've seen in that regard. Has it changed over the 3 years parallel to the public health changes, or should it change? What's going on? Are there a lot of grandparents raising kids? What's the response to the children?
So I can speak to, I actually, right before deciding to get into academia, and I don't know which is more chaotic, working with DCS or working with academics, but I was part of under the Daniels administration, the big practice reform, where we were really trying to as what we heard earlier, have this kind of wraparound approach. And really trying to keep families intact, but also making sure that children everyone involved had access to resources, and we were building that capacity. However, that kind of engagement was also required to have case managers to have a caseload no more than 12 or 17, and actually it was there when they were kind of putting those guidelines into those parameters into place, because before that we had ongoing issues around child fatality. So we had this very proactive, very family-centered approach, and then we saw things get rolled back around that, and all of a sudden, and I think parallel to the opiate crisis, because I went from working with families who were struggling with methamphetamine to now I watch them misusing prescription opioids in place of the lack of of ingredients to make meth. And so going forward, kind of in all of this, at least with my colleagues who still work in child welfare, they went from a caseload trying to get down to 12 to 17 to back up to 50. And if we're really going to be protecting children, just like we want to protect the public's health, we have to have the capacity to do so. So at least from what I'm hearing in the field, just from colleagues, yes, that there are times that they're staying with a kid in the DCS office overnight because they don't have a placement. I see more and more signs around foster parents are needed. Back when I was doing that work and even doing some research with kids aging out of the system, I mean, we were just reimbursing foster parents like maybe $50 a day, depending on like the needs of the child, but also asking them to do a lot more. We know that has been, some of those subsidies have been cut back over the past couple years, and so. I mean, for the longest time, even still wore the lanyard I had that, how are their children? They're doing just fine with DCS, but from what I'm hearing, in that sector, things aren't well, and I feel like we're putting them at risk because, as you said, like looking at the availability of treatment on top of, and I think there's some innovative stuff happening with community hospital, but looking at the fear of law enforcement if I go access help as a parent who's struggling with substance misuse disorder. So, I think it's just part of that vicious cycle.
I forgot to invite Brittany and Dr. Walthall back up to the stage for this part of the show. If you guys could come up here, I'll give up my seat, and then we can keep going with Q&A.
right,
I have
I was
more
gonna
questions,
add to
but I was. Oh yeah, please do.
The
Sorry.
so we know over half the kids we're serving in southern Indiana counties aren't living with parents. So what our staff has done, because we try to always use inclusive language, and we don't even use the word parents. We only talk about the trusted adults, the people who care for you is the kind of language we use with the kids, because so many don't have parents actively engaged in their lives, whether it's incarceration, addiction, or whatever issues. So it's only gotten worse from our perspective because it's now just more common that they don't have parents in their lives versus, less common. So it's definitely become an issue. A lot of the kids do come up to our staff after class, and they're very worried about an older sibling or someone they know that is using drugs because they are afraid of arrest or police or DCS. So that fear factor, the kid already may have been taken away, but now maybe they live with grandma and grandma's using. They don't want to say anything because they saw what happened when they said that mom was using. So it definitely, from the kids' point of view, they've learned to keep bigger secrets than they did before, and are just very anxious about talking about what they're seeing in their homes and everything because they don't want to get taken away again.
And I'll just briefly add to the reunification issue with families is something that we look at in our data, because that tends to be something people are willing to listen to more than, oh, they're on medication-assisted treatment, they're not using as much, but showing that your reunited family is getting employed, that's another big one. Showing responsibility, that type of stuff speaks to audiences that might not listen to other arguments. With the child, so we're trying to do some partnerships right now on a project with DCS, and I'm very hopeful to be able to use some data to demonstrate the benefits of an ED-based overdose program for linking people to treatment from that. And then finally, I think we need to make sure that courts are okay with parents being on evidence-based medication-assisted treatment to have their kids back in the home, because if that's sort of a moving target depending upon who people are engaging with in the system.
So Julie, I'm telling you things that you already know, but I think for the rest of the audience it's helpful to share. So Julie runs the Commission to Improve the Status of Children in Indiana, which is a multi-agency collaborative across public health, social service, criminal justice, DCS sectors, and she does a phenomenal job really keeping kids at the forefront of all of our policy work. So, go you. But one thing is when I started on the commission now 3.5 years ago, we had this incredible stat that we were #2 in the country for children who are in foster care because of parental incarceration for substance use disorder. So that's not a #2 we're looking for. I'm a little more competitive than that to be that far behind. So, we've come a long way, and really what's going on in DCS right now is really awe-inspiring. The work that is and the synergy that's happening as we think about that we're all taking care of the same folks. And so the synergy between FSSA and ISDH and DCS to really have these incredible goals that are the same, and how do we use all of our tools to get there, are pretty incredible. I have a couple of just quick examples of how that works. The first is that we are blending our funding streams so that we're taking care of medication-assisted treatment for families who have kids in the foster is an ER nurse by training, and so she thinks of reunification as discharge. And discharge from the ER is a really big metric that we want to hit, and so reunification or permanency with kids is important. Dr. Box and I talk about ACEs a lot, adverse childhood experiences, and we're in a bit of a pickle when you talk about kids in foster care and substance use, because being in a home with a caregiver who has substance use disorder is an ACE. That's one. Removing a kid from a home with a parent who has substance use disorder is also an ACE. So how do you pick between those two? And you don't, right? You pick the right thing for the kid and the family in this holistic view so that you can support. And so everybody has to be removed is maybe not the right answer. And so it's choosing and empowering our family case managers who are in the field with evidence-based practices and support from home, central office, so that we can really start to move the needle, pun intended, I guess, for these outcomes, so that even though we know that all these kids, just by virtue of being in these situations, have a 1, how do we keep them from having 4? I often joke that it would be really nice if we could all wear our ACE score in one of those little cartoon bubbles above our head and walk around and change the way that we interact with each other based on I walk around every day with a 5. Not me. I'm so lucky. There's no reason to be sitting in this spot other than I have a 0. Right? And I'm grateful for that every day. And it's the circumstances in which we find ourselves that have to inspire us to do more. But if you're in the grocery line with somebody that had a 5, wouldn't you change your trauma-informed care of them while standing in the grocery line? I think we can do that. Those are the things that we can do across the public and private sector to really move this forward. I also just wanted to make a comment on, Dennis, thanks so much for all of the work that you're doing. One of the main reasons that we're doing the ECHO model of training for medication-assisted treatment is that those waivered providers, they may have their waiver but not be actively prescribing. What the ECHO model is meant to do is support them in becoming active prescribers and connect them to all the other stuff that it takes to do more than just write a prescription. And so the 120 providers that are in our funded ECHO program are starting to learn how to make those connections and make them embedded in their process, because we know that there's incredible stigma reduction by having your MAT prescribed by your primary doctor. You go and get your hypertension taken care of and your headache and your MAT all at the same place, and there's no sign above the door that says people with substance use disorder are coming here. But that other connection has to be made in that same spot so that they can have their evidence-based treatment. One of the other things we're really supporting is integrated care, and so co-location of primary care and mental health in the same spot. That we have certified 12 spots across the state that are doing that, and we have a kind of fun little reimbursement package that helps them do that in the same spot, because it turns out that you actually can't take someone's brain out and separate it from their body and send it over for one therapy and then take care of them at the same time there. So that integrated care model, we're making some really good strides on that. So again, big kudos to the commission for finding its voice this year under Julie's leadership and helping herd all the cats of our multiple agencies all to head in the right direction.
Come on, no other questions? All right, I got one more. Dennis, I wanted to give you a chance to plug one of your recent papers, at least. We talked a little bit about naloxone access, but part of administering naloxone, according to the law, is that you dialed 911. And we touched a little bit on the fear of law enforcement, but what did you find in that paper?
Yeah, I mean, this has been sort of the thing that everyone's interested about. Just to give some background to folks who might not know, we have been working with the State Department of Health through a CDC-funded grant to distribute postcard surveys inside naloxone kits that have gone out around the state. And since we regularly get these, you can only ask so many questions on a postcard, but we recognize it's very important to have something easy for people to fill out and send back. And one of the things that we get when they pick up the kit, a lot of individuals have responded that, well, first of all, we've learned most people are calling 911, which is connected to our state's current Good Samaritan protections, that to be protected as someone who calls 911, you administer naloxone, you call 911, you remain present, you cooperate with the police, and that allows you to some certain immunities related to drug possession and paraphernalia possession, and that most people are calling 911, so it seems they understand the law, or at least recognize the importance of calling 911, but there's this significant minority who are not calling 911, and a majority of them are not calling because they're afraid, they state fear of the police. Or the other option is that the person wakes up and seems fine on their own. But overwhelmingly it's fear of the police, which, the way that story gets turned around when I tell it to folks is often, oh, these silly substance users, they don't understand there's this law that protects them. But truthfully, when you look at the law, it's really confusing. It's actually not a Good Samaritan law on its own. It's embedded in our naloxone access laws. Because of that, truthfully, for the protections to come into effect, you have to administer naloxone, which means if you don't have naloxone and you call 911, you technically aren't protected. So that's another issue with this, right? And those people probably are going to need someone to show up for emergency medicine more than if naloxone was administered, because they don't have anything. So those are just some barriers that are currently out there. And some of that comes from just past interactions with the police. Some of it comes from negative interactions with police officers in light of the law already being in effect, although I've actually heard some of it isn't the police, it can be the way EMS treats them when they show up. So there's a whole bunch, and I've heard really great stories about police too, doing excellent things when they show up, and we really need to make sure police are a partner in this and understand the law and understand how to enforce it. And the last point that I'll make on this, that is where we're going next with the research, is that we currently have a new overdose homicide law that has been that is passed in the state that goes into effect this summer. And basically what that says is if someone dies of an overdose, that the dealing of that drug to that person could essentially result in higher level felony convictions. But the law is written broad enough to where it's not just a monetary transaction that has to happen. If I gave Carrie some drugs and she overdosed, that could qualify me for having that felony conviction. So there's potential that that could make people even more reluctant to call 911. And so we're adding that as a question to our cards to see if people would be more or less likely to call 911 in light of that.
Okay, thank you everyone for coming. This has been great.